So let us all have a nice time and welcome all the panelists and also the eminent panelists and also our viewers who have taken some time to join, because today we have an uh, very important topic to discuss: the diagnostic advancement in sepsis. And why this date particular was chosen, because 13th September all over the world, the critical care people and our other associated specialties do celebrate the World Sepsis Day. And also in and around that time period, we do a lot of programs to commemorate or to actually spread awareness or focus our uh, your activities in and around one of the most killer diseases, the sepsis, which is the leading cause of in-hospital mortality and fifth major cause of all causes of death itself. So today we have a lot of important eminent panelists from India, from UK, from US, and we would be discussing a lot more interesting topics regarding and challenging topics regarding the diagnostic aspects. But before that, we have certain important topic to also be presented, which would be done by one of my friends, Dr. Devkishore Gupta, and also from our friend in Singapore. So I would invite Dr. Devkishore to quickly give you an overview of the diagnostic aspects of sepsis itself. Dr. Devkishore.
Thank you. Thank you, Dr. Kaur. I'll quickly share my screen. I hope this is visible.
Yes.
Yeah. So good evening, everyone. So I'll be talking on role of diagnostics to support antimicrobial stewardship in sepsis, especially in the COVID-19 pandemic situation. So I'll just set up a very brief background, then we can have a panel discussion. We have galaxy of eminent speakers joining across the globe. Well, we all know that sepsis cost to human life is quite significant, and the patient mortality increases with increasing severity. If you can diagnose sepsis in very early hours, so mortality is around 6%, but if it goes into the septic shock stage, the mortality rises up to 34%. And we also know that—
Sure. I think you are showing your presenter view. You might want to switch your view.
That's it.
Thanks. Yeah. So, and every hour delay in antibiotic administration increases chances of death by 7.6%. So you can imagine 2 to 3 hours delay in starting the right antibiotic can actually increase the mortality to a significant and possibly irreversible extent. The sepsis death toll by the minute in India, 23 people are diagnosed with sepsis each minute, and every 2 minutes, 10 people die from sepsis. So that means by the end of this 2-hour meeting, some 600 people, including 2 neonates, would have lost their lives. So this is really scaring data, and we must address, and rather we must try to address this in a better way. And early recognition and treatment can lead to decreased time to treatment, which is definitely essential to target your antibiotics and other management. It reduces the overall length of stay and sepsis-related mortality rates and morbidity as well. So improvement in patient care metrics can help elevate hospital ratings, and which is definitely, taking an important step in today's developing countries as well, and hospitals' overall community reputation. So the bottom line is you have to move sooner and you have to act faster. So Beckman Coulter is the only company, and they're having a huge variety of IVD testing for all your sepsis testing. So like common unique IVD tests, and it supports institution-specific sepsis management protocol, and this can also automate and expedite delivery of time-critical results. So you can see almost all possible diagnostic platforms exist under Beckman Coulter. And not only that, there is an impact on automation and workflow. So they have an automated processing autoplaque. So whereas you receive into LIS and load into autoplaque and remove and take plates to incubator, so essentially you can cuddle down, you can obviate at least 4 steps, and definitely you can understand there's huge impact on productivity. So one fully automated autoplaque specimen processor can automate the workload of up to 2 full-time employees. with a fully optimized workflow. And this is very, very important in this constrained situation when you're having excessive sample load, when you're having reduced manpower. And so redeploy these saved resources to manage additional volumes and provide additional support for technicians. And definitely this is useful for staff safety. So this is a summary coming from IFCC of the recommended test in COVID-19 management. I think this is well addressed, well talked about, but still to showcase that we have all these biochemical markers. We have CRP, ferritin, procalcitonin, IL-6, cardiac troponin, and other stuffs. And this is an interesting one, although well known, the sepsis biomarkers kinetics. So what we know about this procalcitonin, so this rapidly decreases with effective therapy. So once you institute the source control and administer the right antibiotic, so this becomes a very good prognostic marker. And perhaps there are enough studies to show that procalcitonin perhaps predicts organ failure better than CRP. Recommendations for biochemical inflammatory markers, especially in COVID-19, we all know that increased CRP, ESR, ferritin, IL-6, procalcitonin associated exaggerated immune response, poor outcome, and poor prognosis. Whereas there are some additional advantages with procalcitonin. So this can also identify individuals with bacterial co-infection. So this is very useful that, we have seen that COVID-19 is heavily associated with secondary bacterial infection, but possibly this is a wrong step antimicrobial stewardship to start every patient on broadest spectrum antibiotics. So if you can follow up those patients and perhaps it better when to start the broad antibacterial agent instead of starting empiric antibiotic for each and every COVID-19 patient. So it also reflects on severity, it can predict outcome, and you can manage antibiotic treatment. You can de-escalate your antibiotic, you can stop your antibiotic based on the procalcitonin and definitely based on overall clinical condition of the patient and follow the efficacy. Now coming to access IL-6. So this is the claim for COVID-19 use coming from EUA claim. The access IL-6 assay is an in vitro diagnostic test, and we all know that this is for human serum and plasma. This is used to assist in identifying severe inflammatory response in patients with confirmed COVID-19 illness to aid in determining the risk of intubation with mechanical ventilation. So this is very interesting that this can have an additional advantage that you can actually stratify which patient will be requiring some assisted support in the longer run or during the future stay in the hospital, definitely in conjunction with clinical findings and the results of other laboratory testing. So this is also used to aid in the study of inflammatory disease. And so this is a very good study. It was conducted in Spain where PCR confirmed COVID-19 patients, some 75 patients were considered for this, and they have access IL-6 concentration. So it was well evidenced that if the IL-6 is more than 35, when the patients presented in emergency department, they had increased risk for mechanical ventilation during their hospitalization. So you can actually predict what is going to happen, or at least you can monitor those patients very closely. So this is another biomarker which is also important because we all know that there are a lot of patients present with cardiac events in the COVID-19 situation, and the connection between troponin I and COVID-19 is established. A considerable proportion of COVID-19 patients, some 12 to 28%, presented with elevated cardiac troponin levels. And the elevated troponin has been shown to correlate to an increased likelihood of need for ICU care. And at the same time, the cardiac injury can also be predicted in 1 in 5 patients. And also we know that there is tenfold mortality. So you can again better monitor your patients and give the right support at the right moment. So this is a typical sepsis care pathway. We have this MDW. My next speaker will be discuss on that. And once the patient lands up in sepsis in emergency department, so definitely once you have the patient diagnosed as having sepsis or septic shock, then you have this entire gamut of testing, IL-6, procalcitonin, lactate, CRP, you collect the blood culture, you collect the appropriate specimens and send it for culture and sensitivity, and definitely you can start the empiric antibiotic. And after you collect the samples and without wasting much time. And so I'll come to the next part of my quick discussion, that the clinical impact of molecular diagnostics. Now we have started the empiric antibiotic based on your local antibiogram. Now, how we can streamline these antibiotics. So this is kind of alarming data that coming from India based on 17,000 hospitalized COVID-19 patients. So we have seen that 78% of patients acquired secondary bacterial infections and gram-negative bacterial infection, and 74% gram-negatives were carbapenem resistant, and 72.8% of them are Klebsiella pneumoniae, and 92% was Acinetobacter. And 72% of deaths happened because of secondary infections, and that was attributable to gram-negative bacilli. And these 75% of the patients acquired this within 48 hours of hospitalization, and there are 2 to 3-fold increased BSI rates in most hospitals. So we can understand that the secondary infection rate is pretty high. So this is across the globe. Possibly the infection control programs are at stake, but somehow this is well evidenced, and this is high time that we have to properly understand the genetic mechanisms for optimizing the antibiotics. Otherwise, almost all patients in your ICU will be getting colistin, and possibly that's not the most desirable condition. So we have this expert Carbapenem assay which can detect the resistance genes, KPC, NDM, VIM, OXA48, IMP, whereas the time to result is just 50 minutes. So we have these rectal swabs and perirectal samples. So this is essentially for screening, and for the therapeutic strategies for optimization of antibiotics, you can do the testing from Carbapenem non-susceptible colonies. So this is how you pick up the bacterial isolate and send it for testing, and you get the report in 50 minutes. So you just need to insert the swab and vortex and transfer the sample reagent to the cartridge, and just you insert the cartridge and start test, and you're ready to go. And these are all resistance genes which can be picked up by this novel assay. So you have all KPCs, IMP-like, all VIMs, all NDMs, and OXA48-like. So the therapy management of CP, this is actually very important, how you fine-tune your antibiotics. So once you start your empiric therapy, so we know that for extensively drug-resistant situations or for multi-drug resistant situations, combinatory therapies work better, so with at least 2 drugs. Often we need to give meropenem and colistin or some other antibiotic with colistin, but we are unsure that whether the other companion antibiotic is working well in synergy with colistin. So genetic resistance, the understanding genetic resistance will give you a fair amount of idea whether you have chosen the right companion antibiotic with colistin. And definitely colistin monotherapy is not recommended, and this is high time you must understand whether the other antibiotic which you have prescribed with colistin is really working, or this is just causing side effects only. And definitely colistin monotherapy and colistin therapy as a whole has its own side effects, nephrotoxicity, and it's also poor pulmonary penetration. We are having new drugs which are going to be launched. Some of them have launched. So rapid diagnostic tests differentiating the Carbapenem genes should be integrated into antimicrobial stewardship programs to impact patient management therapeutic choices in a timely manner. So this is essential that we have to start this rapid diagnostic test to have a robust antimicrobial stewardship program. So how does knowing resistance mechanism drive appropriate therapy? Now, well, you have KPCs, you are having these active antibiotics like colistin, aminoglycosides, fosfomycin, rifampicin, and also you have ceftazidime, avibactam. Whereas for metallo-beta-lactamases like NDM, IMP, and VIM, you have a almost same set, but definitely you see that your ceftazidime avibactam is not going to work here. And for OXA48, OXA23, again, you can use your ceftazidime avibactam or colistin and other antibiotics. So once you understand these resistance mechanisms, then it becomes easy for you to choose the right antibiotic, whether you need to continue with colistin, or if at all you are lucky enough to give ceftazidime avibactam monotherapy, or sometimes what is the best drug to add with colistin. So you have this data available with us, and you can do this in a convenient and scientific way. So these are the new antimicrobial agents, and you can see this ceftazidime avibactam. This works well for KPCs and OXA48, and for meropenem vaborbactam, which is active against KPC, and the ceftolozane tazobactam, which is not active against all these, and imipenem relibactam, this is again active against KPCs, and the cephalosporin ceterophore, this is active against all these genes, and aztreonam avibactam, which is going to be launched maybe in the next year. Year after, this is also against all these resistance genes. So essentially, once these antibiotics, which are right now in pipeline, are going to be launched, you must have a fair amount of knowledge in these resistance mechanisms to utilize them better. So I'll stop over here. Thank you so much for the kind attention. So over to you, Dr. Arindamkar.
Thank you, Dr. Dev Kishore. Short and sweet. And we would take most of the questions because we will be asking a lot of questions in fact in NA. So I would invite Madam to speak on the MDW, which we all are eagerly awaiting. That what is the new thing? Dr. Poi says we. I'm extremely sorry. Maybe I may not have pronounced it correctly. Right? Difficult for the Indian elocution and others, and he would be speaking about the monocyte distribution width, the monocyte volume distribution width, whatever, whether it could be a novel sepsis biomarker along with the other existing biomarker, particularly in the emergency department. Yes, madam.
Thank you very much, Dr. Kar. Can I just confirm that you can hear me and see my slideshow?
Yes.
Okay.
You are.
Okay. So good afternoon, everyone. My name is Sue. So Dr. Kar did a very good job in pronouncing my name. I'm the Regional Scientific and Product Marketing Manager from in Asia Pacific for Beckman Coulter, and I'm very happy to have the opportunity today to share with you some information on our new hematology parameter, monocyte distribution width. It's not a new parameter, but it's definitely a novel sepsis biomarker that can be used in the emergency department to help physicians detect sepsis earlier. So what exactly is monocyte distribution width? It is really just a parameter that measures the distribution of different sizes of monocytes. This is monocyte distribution width, or MDW for short. And MDW is the identification of different sizes of monocytes, in particular larger than normal monocytes. And you may be more familiar with RDW, or red cell distribution width, where we use RDW to differentiate different types of anemia. So with MDW, or monocyte distribution width, we are identifying sepsis. MDW can really be summarized into 4 key points. First of all, this marker is FDA cleared for the early identification of sepsis and also CE marked. And in this aspect, it's really important because actually over the past couple of decades, many hematology parameters have been indicated to have some utility in detecting changes in the white blood cells as they respond to an incoming infection. However, monocyte distribution width is the only one that has been cleared by the regulatory authorities for early detection of sepsis. In addition, a monocyte distribution width is reported as part of the complete blood count with differential. So there's no workflow changes. The minute a CBC or a complete blood count is ordered with differential, MDW is available as an additional information. So there's no change to the workflow in the emergency department. There's no need to order another test. And I think more importantly, there's no added cost to patient. As you know, there are many biomarkers that are available, both from the core clinical laboratory as well as point of care. But I think the key strength is that MDW can provide additive diagnostic information coupled with white blood cell count with no workflow changes and of course no cost to the patient in that sense. And it's available very early on simply because it's available with every CBC with differential that's ordered. And usually these are ordered very early on when patient is coming into the emergency department. So the physician does have additional information available early on to help increase or decrease the probability that this patient may develop sepsis later on. So I think overall, in summary, MDW can help to increase your index of suspicion of sepsis to assist with faster triage in the emergency department. So what are monocytes? Because we will be talking about monocyte distribution width, and what's so specific about monocytes that prompted us to really go and look at this marker. So monocytes and neutrophils are part of the innate immune response. And as you may know, these are the early responders to an infection, be it a viral, fungal, or bacterial infection. And in the early days, when we're looking at these hematological parameters, we actually looked at neutrophil distribution with neutrophil volume as well. But what we found was that the monocyte distribution width was the hematology parameter that responded the best, in response to an infection that was likely to turn septic 12 hours later. So we actually took that parameter and further, put it into a large-scale clinical trial for eventual FDA submission. So that's kind of the backstory of how we ended up developing monocyte distribution width as a marker for early sepsis detection. So, monocytes actually play two key roles. First, they migrate to the source of infection. And the key thing here is that the infection can be bacterial, fungal, or viral. So in that sense, MDW does not differentiate between the types of infection that eventually turn septic. When you see a change, an increase in the MDW, it's indicative of all types of sepsis as a result of different types of infection. It's not only for bacterial or viral or fungal. And the macrophages and monocytes release cytokines, resulting in a cytokine storm. The cytokines activate the circulating white blood cells, resulting in toxic granulation. And you may see leukocytosis. And this is, it results in a further vicious cycle of more white cell activation. The bone marrow releases more granulocytes in the blood, and some of which you do see, which are immature, and you do see this left shift in terms of bands. But I think overall, this progressive cycle or vicious cycle of activation of white cells, it's part of the body's response to the incoming pathogen. And the monocytes are actually one of the first cells as part of the innate immune response that responds to this incoming pathogen. Therefore, measuring the changes in monocytes as they respond to this incoming pathogen may help us to actually understand whether or not this patient may eventually turn septic. So just to share with you some data, this is a representative histogram. Let me see if I can move this a little bit so that it doesn't lock. Yeah, so this is a representative histogram of a complete blood count differentiation and measurement of monocyte distribution width. You can see that this is a non-septic patient. And in this patient, these are all the different white blood cells. And you can see that the monocytes are here, neutrophils, eosinophils, lymphocytes. So the monocytes are the green population here. And in an infection, as monocytes respond to an incoming infection, they do change in morphology and size. And this change in morphology and size is reflected by this very round type population kind of stretching out and eventually increasing in volume. And this increase is actually measured as monocyte distribution width. So what you see here is that this is the normal monocyte volume distribution width control. And in the case of a septic patient, there is a shift rightwards. So in this particular graph here, so overall, the MDW value or monocyte distribution width value will increase. And the magnitude of this increase above a certain cutoff. And for this particular case, the cutoff is 20. So above the cutoff of 20 for K2 EDTA tubes, there is an increased likelihood of the patient turning septic. So you can see here that in a non-septic patient, the MDW is below 20 at 19. And in the septic patient, where there are changes in this monocyte distribution width, MDW is above 20. A few additional things. This marker is available for report out on our hematology analyzers. And with the activation of this parameter, it allows for measurement of the changes in this particular white blood cell on the extended volume range. So for those of you who may have done flow cytometry before, you may recall that most flow cytometry will be able to measure changes in monocyte distribution width. However, there is a certain limit to which you can measure the monocyte distribution width, because if you don't measure it on an extended volume range, the monocytes may cluster right at the top near the y-axis. But with the activation of this particular parameter on our hematology analyzers, you're measuring the change in monocyte distribution width on an extended volume range, and this allows for more accurate accounting of the monocyte distribution width value here. So like I mentioned before, MDW is reported automatically as part of the complete blood count differential test in adult patients as seen in the emergency department. And very often we do get the question of, how does MDW look like on the patient report? So this is a typical report that you may see, and MDW is just reported as part of the complete blood count differential. So again, this further emphasizes the fact that this information is available with no impact on workflow in the emergency department, and there's also no need to order an additional test. This information is available whether it's above or below the cutoff to help the physician in understanding whether or not this patient may turn septic later on. So we've had quite a number of studies published on MDW since the very first pilot study was published about 4 years ago in 2017. And this is our multi-center clinical trial that was published in 2019 at Ohio State University. And this study actually enrolled more than 2,000 patients who had complete blood count drawn at presentation emergency department. These are all subjects presenting to the emergency department, in that you can see the inclusion criteria is quite broad. They weren't cherry-picked for particular conditions or only patients with certain types of prognosis were admitted. No, all subjects presenting to ED were enrolled in this study. The only inclusion criteria were shown here below, where the subject must have stayed in the ED or hospital for at least 12 hours, because this is necessary as part of the study design to collect sufficient medical record data to confirm sepsis or no sepsis. And actually, due to this particular inclusion criteria, there was actually a higher percentage of sick subjects. So in the sense, the sepsis prevalence in this particular study population was 18%. And this was only for adult patients aged 18 to 89 years old. So what do we see? This data is actually represented by receiver operating characteristic or ROC curve. And the y-axis looks at sensitivity and the x-axis looks at specificity. So a perfect biomarker, a perfect assay would have 100% sensitivity and 100% specificity. And you would see a data point right at the top left of this ROC curve. So the closer the deepest part of the ROC curve gets to the top left, the better the assay is in regards to approaching 100% sensitivity and specificity. So in this study, you can see that abnormal white count alone had an area under the curve of 75% in identifying sepsis. And this is looking at sepsis 2 definition using the Sears scoring system. Abnormal MDW alone, which is the green line here, had a slightly better area under the curve of 0.79 or 79%. However, when you combine both abnormal MDW and abnormal white count under the curve, the area under the curve then jumps to 85%. So this is a full 10% increase from the abnormal white count alone in the early identification of sepsis. And I think just for comparison, it's also important to note that looking at lactate, which is the blue curve here, has an area under the curve of 59%. And the combination of abnormal MDW and white count, as depicted by the purple line, has a 26% better area under the curve than lactate in the early identification of sepsis. So I think this distinction is really quite key, because lactate's primary role in sepsis, as you may know, is to really determine just how severely septic a patient is. At this point, the organs may be starting to fail, which contrasts quite sharply from MDW's role in the workup and management of sepsis. MDW is really meant as a marker for early identification of sepsis, right at the point where patient is presenting in the emergency department. So I think both markers have very different roles to play here in the management of sepsis for patients. So I think identifying sepsis in patients presenting to the emergency department is not always very clear cut. I remember a few years ago, I invited one of the ID doctors from, I think, France to come to Singapore to speak. And, he gave me this analogy, which I really like. He says, in the emergency department, we always can catch the really big fish. The patients who come in who are really, really sick. We know immediately what to do. You don't have to tell me what kind of biomarkers or what kind of protocols. We know immediately what has to be done. But he says that, what keeps him up at night is trying to catch the little fish, the ones that can slip through his fishing net. So I think the key is that there are always some septic patients that present to the ED with classic signs and symptoms, or whose history and exams are strongly suggestive of sepsis. Using the systemic inflammatory response syndrome, or SIRS, to identify sepsis is quite common. However, it's not specific for sepsis, and some septic patients do have very few SIRS criteria. So in this study, in our clinical trial study, we actually looked at, the percentage of patients who had a small number of sears or a low SOFA score. So you can see here that a full 1/3 or 33% of septic patients presenting to the ED had either no sears or just 1 sears criteria. So I think quite an ambiguous kind of presentation. And for hospitals who are using sequential organ failure assessment or SOFA score, they do have a similar challenge too. And in this particular study, we saw that 88% of patients diagnosed with sepsis actually originally presented with 0 to 1 QSOFA. And in that sense, they may not be identified as septic by using the QSOFA scoring system. So these are, in a way, those small fish that I guess that particular doctor was telling me he was concerned that maybe slipping through his fishing net in the emergency department. So again, MDW can help to increase your index of suspicion of sepsis to assist with faster triage. And I'll show you some data in the next slide with regards to this. So we have seen additional data to point to how MDW can aid in diagnosis when that patient doesn't present with classic symptoms. So as I mentioned earlier, MDW is really not a definitive rule in or rule out, but it really helps the physician to increase his index of suspicion of sepsis. And in fact, when I first started presenting this data to many doctors, everybody comes back and tells me, well, it's not a golden bullet. So my response to them is always, it's not meant to be a golden bullet. I think it's really just additive information that's very available very early on as part of the CBCU differential at no additional cost or change in workflow to the physician in the emergency department. So if you take a look here, right, in a patient presenting with 1 sears and a normal MBW, okay, his patient has a very, very low probability of developing sepsis too. And however, if this patient with 1 sears has an abnormal MDW at presentation, you can see that the probability of patient developing sepsis does increase up to 4-fold. And this trend is similar. So if you're looking at the blue bar, which is the sears score, plus a normal MDW as compared to the purple bar, which is the sears score plus the abnormal MDW, you can see that there is this trend of increasing probability of sepsis. And for patients who present, for example, with 4 sears criteria, I think it's very clear on how to manage these patients. But I think one of the greatest utility of MDW is for patients with a lower initial clinical suspicion, where if they have a normal MDW with 1 sears score, and this probability is increased by almost 4 times when their MDW is abnormal. And we see a similar trend for hospitals who are using the SOFA scoring system. So looking at QSOFA scoring system, you can see that for patients coming in with either 0 or 1 QSOFA, you can see that if the MDW is normal, as compared to when the MDW is abnormal, the purple bars here, again, the probability of suspicion of sepsis does increase by more than 3 times. So again, we do see that the highest utility of MDW is in such patients where they have a very low initial clinical suspicion. So I think this typical sepsis care pathway was shared initially in the earlier talk. And I really want to highlight that actually MDW does differentiate from other typical biomarkers in the sepsis care pathway. MDW is available as part of the routine labs, right? When you order your complete blood count with differential, and together with signs and symptoms that can indicate possible sepsis. So whether you're using the QSOFA or systemic inflammatory response syndrome, can help the physician to understand the probability of this patient developing sepsis within the next 12 hours post-initial presentation in the emergency department. And very often the other confirmatory tests like PCT, lactate, or CRP, or even IL-6 if your hospital is using it, these confirmatory tests are usually ordered much later on in the sepsis care pathway, where the physician is a little bit more convinced that this patient may have the likelihood of developing sepsis later on. So as you can see, these biomarkers are quite distinct from MDW in terms of utility in the typical sepsis care pathway. So we've looked at the data relating to sears and QSOFA. Another way to look at the data is simply based on sepsis symptoms, including abnormal temperature, tachycardia, hypotension, and altered mental status. But the clinical interpretation is really the same. So at a pre-test probability of 5.3% or 5.3% prevalence of sepsis in the study population, the post-test probability or the actual probability of patient being septic increases where MDW is positive. So you can see here, for example, the patient comes in and in a pre-test probability, so before having the results, the pre-test probability is 5.3%. With a normal MDW and a normal white blood cell count, or even just a normal white cell count, with no MDW information available, there's almost a 0% probability of patient developing sepsis. But you can see that if there is a positive white cell count, but normal MDW, again, the post-test probability of patient developing sepsis is still fairly low. But with the availability of the MDW as an abnormal, so the positive here indicates abnormal value. So if the patient is abnormal for MDW, again, this probability of patient developing sepsis in emergency department does increase by about threefold. And this is for patients who had one or less symptoms at presentation using the sepsis 2 criteria. So I think this is quite important because really 60% of the ED patients who were diagnosed with sepsis in the pivotal study that was done at Ohio State University actually presented with 0 to 1 symptoms that was used for the sepsis 2 screening. So again, consideration of MDW and WBC combinations can really help to improve specificity of sepsis detection. And consideration of abnormal MDW can increase the overall sensitivity of sepsis detection as well. We've also had a lot of questions from other clinicians on how can MDW be used in clinical care. And this is a typical protocol from one of the hospitals where MDW is currently being used clinically. So at this particular hospital, where a patient has identified infection, suspicion of infection, or history of suggestive of infection, coupled with 2 or more of these CS criteria, and in this case, this hospital regarded MDW as a 5th CS criteria. Then the patient is placed in the hospital sepsis care pathway, where all the various steps for the sepsis care protocols are being initiated. So I think very early on, when we first started developing this this biomarker and started collecting the data, we weren't very sure how to use it. And it's really true, I think, the real life, bedside experience of the clinicians in the emergency department that we started to understand what was the best way to use it. And the understanding is that really its utility is the highest when it's used as part of the additional CS criteria or as a SOFA criteria very early on in the sepsis care pathway within 30 minutes of presentation to the ED, for example. And we don't have the claim for this specifically, but a lot of physicians have said that it's really kind of like a screening marker together with your CBC or with differential. And if the patient checks all of these boxes, including the CS criteria, abnormal MAW, as well as suspicion for infection, then they will admit them into the sepsis care pathway, where the various tests, like for example, lactate, will be ordered, as well as administration of broad spectrum antibiotics. So I think, finally, in light of the current pandemic, I think we can't get away from the COVID discussion, right? So it's really important to remember that sepsis is a common cause of death in COVID-19 patients. And I think the uniqueness of MDW is that it's not specific to, say, just bacterial, viral, or fungal infection alone. It's actually really applicable to septic patients suffering from a variety of different types of infections. And what we see is that while MDW is not a test for COVID-19, the leading cause of death that was published in Lancet last year in 191 patients, hospitalized patients with confirmed SARS-CoV-2 was actually sepsis. So again, there can be some utility in this case in trying to screen for sepsis using MDW in such COVID-19 patients. So I think in summary, I still want to come back to my 4 main points. Right, MDW is really a first of its kind hematology-based biomarker that was cleared by the FDA and European authorities for sepsis detection in emergency departments. MDW is available as part of the complete blood count differential, which is already routinely utilized for patients presenting to the emergency department, especially those suspected of infection or sepsis. And I've shared with you the example of that particular hospital's protocol where they put MDW as part of a screening protocol within the first 30 minutes of patient admission to the emergency department. So in that sense, there is really no workflow changes, right? Because MDW is part of the CBC differential test. There's no need to order an additional test or to add another test onto the ordering form. And I've shown you that MDW can provide additive diagnostic information coupled with WBC. So generally, we see that if the WBC is abnormal, having an abnormal MDW does increase the probability of sepsis by about threefold if the patient is presenting with 0 or 1 serious symptoms, or having 0 to 1 QSOFA score. So I think this greatest utility is really for these patients who present with fairly mild symptoms in the emergency department, kind of like the small fish that may slip through the net, to kind of go back to that fishing analogy. Because I think that, because the key is that for patients who are presenting in a very severe condition, the emergency department, I think most physicians will know what to do with them. I think the challenge is always trying to determine which are the patients that seem to be okay in the emergency department, but you want to decide whether or not to give them empirical antibiotics, especially in this current scenario that we're living in of increasing multi-drug resistant microbes. So overall, MDW does provide additional information that is available very early on to increase and decrease the probability of sepsis. And I think the strength of MDW is that it measures the change in monocytes, which are one of the first responders to any infection. So by detecting this change, it's a very sensitive marker to detect the severity of the infection that may eventually result in the patient becoming septic later on in the emergency department. And very often I get asked the question as to what is the time frame, right? If MDW is abnormal, what is the likelihood of this patient developing sepsis? How long? Is it 12 hours, 24 hours, 48 hours? So what I can say is that our clinical trial data was based on the 12-hour time frame from the point of patient admission to, they have to be in the hospital for at least 12 hours to get that diagnostic information back. So the probabilities of sepsis developing with a positive MDW was studied with that 12-hour time frame. So I think overall, by itself and in combination with white blood cell count, MDW can modulate the probability of sepsis and developing sepsis over and above clinical signs and symptoms at presentation, whether the hospital is using SEERS or SOFA scoring system. I think we have shown that it does help to increase or decrease the probability of sepsis, depending on whether MDW is normal or abnormal. So I think just to kind of recap, an abnormal MDW increases the probability of sepsis. A normal MDW can decrease the probability of sepsis. And what we have learned in the years that we have, in the past 2 years that we've launched this marker, is that it may be of highest utility in patients with low initial clinical suspicion. So I think with the current World Sepsis Day that's ongoing, sepsis is really a global health epidemic, and we at Beckman Coulter believes that monocyte distribution wave will have a meaningful influence on how sepsis can be diagnosed and managed. And I think to date we have studied MDW in more than 5,000 patients worldwide, and the studies are really still ongoing. So thank you for your time today, and I look forward to any questions you may have. Thank you very much.
Dr. Dev,
yeah, thank you. Thanks for the wonderful presentation. So Dr. Arindamkar, you can take over from here. And Dr. Arindamkar, he's a well-known critical intensivist in the country. So presently he is with HN Reliance as Director of Critical Care. At the same time, he is also General Secretary of ISCCM. And over to you, Dr. Kar. So you can introduce.
Yes, yeah. Thank you. And for both of you, we would be including a lot of questions, and I'm actually tracking the questions put up here in the chat box and question answers. So for the sake of time, I will try to incorporate the questions put up here into our discussion. So welcome to all of you to the Diagnostic Advancement in Sepsis related panel discussion. And let me introduce you, have the honor to introduce you, the fellow panelists. We have Professor Dr. Ashok Ratan, who is a WHO fellow and advisor, as well as one of the senior advisors of one of the biggest lab, Pathkind Labs. Welcome, sir. We have Professor Dr. Neelam Verma, who is an ex-professor and HOD of Department of Hematology, PGI, Chandigarh. Neelam, madam, welcome, madam. We have Dr. Rajadhar, the Director and HOD Pulmonology and Critical Care, CMRI Hospitals, Kolkata, who also happens to be my school, college, everyone senior. Welcome, Dr. Dhar. We have Dr. Tanu Singhal, Consultant Pediatrics and Infectious Disease, one of my favorite speakers, actually, an advisor of ICMR on antimicrobials and therapy and stewardship. We have Dr. Yatin Mehta, who would be joining pretty soon, who is the chairman of Institute of Critical Care and Anesthesiology, Medanta, the Medicity Gurgaon. Then we have Dr. Trupti Gilada, who is the ID specialist, Masina and Prince Ali Khan Hospital, Unishan Medicare and Research Center, Mumbai. Welcome, madam. And we have Dr. Ravi Kumar, who is a senior as well as a friend from UK. He is the lead in crisis management and senior consultant of critical care medicine at the Surrey and Sussex Healthcare of NHS UK. And we have Dr. Rahul Kashyap, who is the assistant professor of anesthesiology and emergency medicine, if I'm not wrong. Correct me, Rahul, if I'm wrong. Mayo Clinic, US. Hi, and you are the most well-dressed. You have already won the award of most well-dressed panelist itself. Okay, so we can start a little bit of it. I hope I'm audible to it. So I would start with Dr. Rajadhar, as he is managing one of the biggest centers in Kolkata itself, and take a lot of patients in both respiratory and general ICU. Is that what is your current practice when you suspect sepsis arising out of MDRO, that is multi-drug resistant organism? And I mean both coming from the community or maybe on hospital acquired.
So Arindam, thank you very much, and hello to everyone. Thank you for inviting me for this meeting. That's a very broad-based question, Arindam, and I'll try and give a broad-based. Yes. We've discussed some of what I'm going to say already. So when a patient arrives in the emergency department and you are suspecting that there's multi-drug resistance, I think the first question is about triaging and isolating these people. And I know we'll go ahead and speak about isolation as we go along in this meeting. The next step would be to look for risk factors, whether this patient has had hospital contact in the past, what sort of hospital contact, whether this patient has risk factors, whether the patient is immunosuppressed. And based on all these factors, you would start these patients on empiric antibiotics. And we know the importance of starting antibiotics early. However, the problem is when you're starting MDROs, you often end up using antibiotics, which you want to keep in reserve, because otherwise you have rampant antibiotic resistance as we have in the eastern part of the country, or well, any part of India and other developing countries. So in trying to do that, what we use in our hospital is an RT-PCR platform called BioFire. The BioFire assay helps us in telling a lot about viruses and a few bacteria when you do a nasopharyngeal swab. You can do a pneumonia panel from a bronchoalveolar lavage in the right sort of patient, and there you get a more focused answer about the sort of bacteria. But more importantly, along with this, you can actually genotype the organism. You can predict what sort of resistance and sensitivity profile these bugs will have. And in doing that, you can give antibiotics which are more focused. It'll help you to de-escalate early and hence reduce the risks of antibiotic resistance that we have in our part of the world. So I think that's probably a broad-based answer, Arindam, that I would want to give.
That was a wonderful answer and entirely summarized. I will very quickly go to Rahul. Rahul, your US strategy in an emergency, you had managed emergency for quite a long. So when you are, what is your current standard practice of a patient who you are suspecting of sepsis? Very quickly.
I don't know if I'm qualified to answer that question. Can you hear me, Dr. Kar?
You are more than qualified. Don't.
Yeah. So maybe I may sound a little bit more cynical, and my apologies in advance. But thing is, I totally agree with Dr. Dhar's comment. Idea is that in ICU practices, I'm a physician scientist, so practices, you think of sepsis for almost all patients, otherwise unproven, like they don't have it. Your goal is exactly same: isolation, look for the risk factors, and then give your antibiotics. I'm a huge fan of interventions. Idea is, when I say intervention, is it doesn't matter at this point that why they have sepsis. Your goal is, if they are low blood pressure, their heart is not functioning okay, fill the tank and give them pressors if they start working. Source control is really, really key as well. And we published that. We did a quality project in 2007, 8, and 9 at the time at Mayo Clinic. We were able to bring down our severe sepsis septic shock mortality from 31% to 27% to 22%. This was one of the lowest in the world at that time. by doing a sepsis response team, which idea was early detection, early antibiotics, 3 hours fluid boluses in 3 hours, first 3 hours in ED or first hour of ICU, and then going after the whole EGDT therapy at the time. Again, I'll not go into controversy. The things which are not controversial are still good, like early fluid bolus and antibiotics has proven to be beneficial. And we have published in CHEST as well, saying that people who survived versus people who died because of sepsis, everything else being the same, one of the differences were that they got at least ½ liter extra fluid in first 3 hours of their hospital stay. So I'll stop there, and that practice has not changed in a sense. If they are hypotensive, fix the hypertension. These biomarkers and other things will tell you when to escalate, what is the source control kind of thing. But the early intervention doesn't change, and that's me being more cynical in this panel so far.
Yeah. Now, not going into controversy, we have less time for getting into controversial things, but I will come to Dr. Ravi regarding the diagnostic strategy in a patient who has come to your emergency with a suspected sepsis. What is your NHS strategy for diagnostics?
And I genuinely, slightly like Rahul, I genuinely feel supremely underqualified to comment on this panel, honestly. You guys are talking about MDOs and whatnot. We don't do any of those. Absolutely not. We still manage sepsis in our ED department with sepsis 6. Yes. You come in, you have a temperature, you look a bit shit, really. You give them some fluids, you take some cultures, you give them some antibiotics, and that is it, really. We at the front door entry. Even now, I work in one of the biggest trusts in this country. Guy's and St. Thomas's, London, is a big hospital where I do half of my work. And we treated the Prime Minister along the same lines. We didn't do an IL-6 on the Prime Minister. We didn't. We just, but I think, to be honest, and I'm sure we'll come to this as the discussions goes on, where we are probably different, I won't say better, I would say different, is our primary care is better, and our triages happen in primary care. And if you have time, I would have to leave in about 45 minutes or so because I've got a bronc to do. But if we have time, I will tell you what exactly we did in our first wave of COVID and what we call as primary care triage. So no, we absolutely don't do anything special at all. We go by clinical science, absolutely by clinical science. We do not do any fancy tests whatsoever. So that's why I say I feel a bit underqualified.
No, but I would rather say Dr. Dhar has spent almost more than 1.5 decades, Dr. Rajadhar. And when
10 years are in them, so 10 years, and I know where Ravi is coming from.
Almost a decade. Yeah. So the question is that when we are actually in India, the situation is much more complex and the incidences of MDROs are much higher. And there are things which are way beyond our control as a clinician, right? So not getting into, again, the controversy, I'm tempted into that, but I will try to avoid. I'll come to Professor Ashok Ratan, sir, that we all know that there are conventional diagnostic tests, as Dr. Ravi was also telling, clinical science and conventional tests like cultures. So what do you think? What are the challenges and shortcomings of the conventional test, which are pushing us towards more sophisticated diagnostic tests? What do you think?
See, the trouble with cultures is that the results come out very slow. So clinicians have to depend upon the clinical judgment and the SOFA score or the Q-SOFA score. Along with that, there are the PCT and CRP, and now we heard about MDW. But in India, the cultures has been, they normally give 1 bottle rather than 2 bottles, rather than 3 sets or 2 sets. So the isolation rate, one is that the results come out after 3 days or so, and the isolation rate is never more than 10 to 15%. So there is a new test which is coming, which is T2MR, which will look at the presence of organism in the blood without having the need to culture. And the result will be available in 3 hours time. So that that test might completely change the scenario of sepsis diagnosis. But at the moment, the cultures are essential, but they are too slow to be really of value for decision making in the ER.
Yep. And sometimes we are not actually collecting the samples properly. We are not collecting the adequate amount, the adequate way, appropriate way, and all others. So there's those maybe adding up to the shortcomings of the high turnaround time. Tanu madam, what is your actually you had been into the ICMR advisory and all others places, and you have seeing a lot many patients. Do you think there had been a notable spike in the recent carbapenem resistance GNP, particularly in the COVID subset of patients? Is it actually altering our decision making when we are choosing empirical antibiotics?
Thank you for inviting me to this panel. So before I go to my question, I would just like to make a point that we have to be careful about investigations, you know, in a patient who comes into the ER, because many of these investigations are very expensive, especially the molecular based. So we have to be sure that they will give us the information that we are looking for before we order them. So in my view, a complete blood count, a CRP, and a set of blood cultures, I think, are the most important investigations for sepsis, even today. And of course, we can maybe add a procalcitonin, and all these other molecular tests, etc., are important. Maybe in a particular investigation of a syndrome, if the patient comes with a particular syndrome. Now, coming to your question, yes, there has been a rise in carbapenem resistant GNBs, and we have been tracking it for the past 10 years, and we found that we were at about our bloodstream, nosocomial bloodstream infections, the carbapenem resistance rates were 50% 2 or 3 years ago, and now they are touching 80%, and we are seeing cholesterol resistance as well. And apart from that, what is really worrying is that we have started seeing carbapenem resistance even in patients coming from the community, like, you know, where you wouldn't normally suspect, but we've had a few patients with community acquired urinary tract infections which were carbapenem resistant, which makes one really worry.
So that's not a good news for all of us.
And
right?
Also one more thing, that apart
Yes,
from the
ma'am.
fact that these nosocomial pathogens are resistant to carbapenems, we are seeing increasing resistance to other drugs which we normally use for carbapenem resistant pathogens like tigecycline. The MICs are going up. In fact, many have MICs of 2, which make them not useful. Fosfomycin resistance is going up. Even resistance to ceftazidime avibactam is going up. So that is also worrying.
So it is encroaching into the almost the rescue agents too. So we have not much of respite. I will come to Neelam,
can I
madam.
take 30 seconds?
Yes, please.
Sorry, Arnab. So just in continuation, I can never disagree with Dr. Tanu Singhal, but one small point. I think one of the reasons why we think about these molecular tests is what she pointed out just now. So in the scenario of having such a lot of drug resistance, if you are to prescribe empiric antibiotics, I think it becomes doubly important to try and know what it is that you're treating in these individuals, especially in the post-COVID era, especially because there's such a lot of drug resistance involved. And I think the solution probably is to try and get RT-PCR platforms which are cheaper. I take her point completely that these tests cost an arm and a leg, but the aim should be to try and isolate organisms, isolate bugs, even if we need to genotype, etc., but bring the cost of these tests down and identify the right sort of patient where to do it. I think that's probably an important point to emphasize.
I agree completely with you that, you know, when they are required, they should be done, when they will change our therapeutic decision making.
I will come to that part, that risk stratification and the ways to choose that which patient, which group of or subset of patients will benefit from this type of sophisticated and costlier testing. But before that, Dr. Ravi, yes. Sir, unmute yourself.
Yeah, I was just going to say that, you know, in answer to, or part answer to the blood culture taking time up to 8 hours, I'm sure you will know that the UCAST has now come up with something known as the rapid AST test or the 3AST test. I think in addition to what Prof. Ratan said, in addition to that, this might be a game changer. So for those of you who don't know it, so with the rapid AST test, in the same blood culture bottle, you will get a break point of hopefully 2, 6, and 8 hours of 3 tests. And in the initial studies, and we should, in the UK, we should be using it sometime this year, hopefully. It shows supreme sensitivity and specificity to Klebsiella and Pseudomonas and stuff like that. So it may well be a game changer, obviously, in addition to what Prof. Ratan said about the TN2. So I'm quite excited about the rapid AST. It may change how things work in terms of timings.
Rahul, anything new in US? Any rapid diagnostics?
I'll not comment on it. I think I'll go with, I think Professor Ratan mentioned, or Dr. Dhar mentioned, that the cultures, the positivity is low. We have the best test, but we know from the research that half of the patients who have infection, they will have negative culture. So that's the biggest, which is not that the culture is not the right.
Biggest,
there are multiple reasons.
The fallacy.
That's the biggest fallacy, and then we have to live with it, or at least make sure that we are aware of the fact and do the early management which could be done.
Right. Professor Neelam Verma, madam, sorry to keep you waiting for a while. I hope, Professor madam. Yeah. Yes. So, but I think the ICMR guidelines, if I'm not wrong, it recommends a surveillance PCR for MDROs, particularly the patients that you are dealing with, the BMT or HSCT.
Dr.
Or maybe, yes,
can I interrupt you? I sent a message that questions 4 and 5, they are not in my domain. The message didn't reach you, it seems.
No, that doesn't know. So, yeah. but would you like to take this that the surveillance of the PCR? Fair enough. Do anyone in your aid, do you are doing, any one of you, a surveillance PCR for the MDROs? Dev Kishore, do you want to give an idea of this?
Yes, actually, in reference to the ICMR guidance that for HSCT patients, so surveillance PCR is recommended. So this is
right.
Carbapenem is production, or MRSA and VRE. So if somebody can throw some light, so whether, because ECDC recommends, they have defined a high-risk population, but how we can adopt these practices in Indian setting.
I will come back to Dr. Trupti, Trupti madam, and then Dr. Tanu Singhal. Would you like to comment on that? Your surveillance PCR for MDROs, particularly in the transplant recipients. Yes, Trupti madam.
Yeah, so we've recently started transplant in our setup, and we have started doing surveillance PCRs. Interestingly, over the last 2.5, 3 years, we've seen a trend changing where probably earlier the positivity rate was less than 10%, and we are seeing it more than 10%, which is worrying. And just like Dr. Singhal was telling us, we are seeing so much more resistance to carbapenems and also VRE. So that's about the surveillance PCRs, and it would be interesting to know what is happening in other parts of the country as well.
Yeah, Tanu madam.
Yeah, so we are doing these tests to detect carbapenem resistance in 2 populations. One is our liver transplant recipients, and second is the stem cell. And in the liver transplant recipients, it helps us define the choice of peri-op prophylaxis, because as per we see a lot of post-transplant sepsis in our patients, which is carbapenem resistant. So if we identify a patient who has carbapenem resistance, then we try and modify the peri-op prophylaxis to include maybe tigecycline or sometimes even poly B in high-risk patients. So that is what we are doing. And in our stem cell recipients, we are doing these PCRs, and we are quite surprised to find that most of them are colonized with carbapenem-resistant pathogens. But that is not dictating our choice of empiric antibiotics in these patients if they become neutropenic and have fever. Because we, if our patient is not having these organisms, is carbapenem-resistant bugs, but becomes neutropenic and is febrile and is sick, we would still go with a polymyxin-based regime. So what I'm trying to tell you is that though we are doing the surveillance, but it is not necessarily dictating our treatment strategy for febrile neutropenia in these patients.
Yeah, definitely. I think that's a very important day. We are also following the same strategy for even for our heart-lung transplant recipients, but the concordance rate is not that high. And at least the initial empirical therapy would be still according to the local or your antibiogram or something of that sort. We'll start with the same, but if non-responders, we would then definitely think of on that part.
The major reason why the surveillance PCRs are being recommended is for isolation. It is not really to determine treatment choices, because it is recommended
for
that
any
if you have a
subsequent
patient,
infection. So it's mostly that we isolate, we be careful for others than the patient
but the
themselves.
rate of carbapenem resistance is so high in our hospitals. You know, almost every second patient has either these bugs or is having infection or colonization.
I have an interesting question on that, madam. I will come back to that. But I will come back to Dr. Rajadhar, and maybe also Neelam madam can also answer that. That the risk stratification you were telling about, right? And can you help to define that risk stratification? And particularly, what sort of risk stratification would you do to recommend these CARBARs? Who should be the CARBAR? One group you have thought, the transplant recipients. Anyone else? Rajan.
So I think, Arindam, the list is probably similar to what we were discussing a little while ago. So along with your transplant recipients, any patient who is immunocompromised from any other cause, so your patient who are on chemotherapy, the patients who are immunosuppressed from an underlying HIV infection, for instance, patients on long-term steroids, etc. The immunosuppressed class would be, the other class would be patients who've had hospital contact, proper hospital contact in the last 90 days would be right up in my list. That would be an important one. Patients who are visiting hospitals on a regular basis, patients on hemodialysis, for instance, or patients on infusions, for instance, who need to come into hospital or on home infusions, etc., would be another class of patients. So I think the list is long. And the problem is that the list is long. If you had to class all the risk factors and do these CARBAR tests on everyone, it's going to be a long list of patients that you have to screen with these tests.
And also then we have a higher incidence. Dr. Ravi, whom do you consider for a higher risk of harboring a multi-drug resistant organism in UK?
If we are accepting a patient from India.
Or if you have visited India.
In all seriousness, we do what is known as, you call it CARBARs, we call it the CPE testing, which is carbapenem resistant enterococci. So we will do that if we are getting patient transfers from the Middle East and the Indian subcontinents. We will definitely do that. And unless we have that result, we won't be accepting that patient. That is number one. There are certain sectors of pan-London hospitals where if we accept patients from there, we will be waiting for a CPE test. But look, like one of the panelists was saying, that every second patient that you have has a meropenem resistant bug. In my unit, have had 2 meropenem resistances in last 3 years. Okay. So just 2 in last 3 years. I have used linezolid in my unit 4 times in last 16 months, despite COVID. And I have not used IV cholesterol in my unit for last 9 years. So your dynamics are very different to mine, aren't they?
I think you are blessed, and we would be very happy to exchange places with you on that part, right? So we don't remember that when we have not used it, right? I would ask one more question that Tanu madam, right, and also Trupti madam. I think I will start with Trupti madam. Is that what do you think the role of molecular diagnostics in making a stewardship program? Do you think there could be some very important role for the molecular diagnostics to build up a stewardship program?
Yes, absolutely. You know, I mean, we've seen the success of molecular diagnostics in precision medicine for cancer, you know, where we've been able to move away just from histopathology and actually zero down on molecular diagnostics and treat them. So Yes, with sepsis, it's an exciting time. I think with the newer molecular diagnostics that will become available, and hopefully cost taken care of, because in our setup, costs do drive a lot of things in management. Molecular diagnostics will definitely help in obviously choosing the antibiotics, but also which patient receives what antibiotic at what dose. And when do we start? So I think the molecular diagnostics is going to be a big driver for precision medicine going forward.
Yeah, I got your way. But one thing I will pick up from your answer is that the precision, right? The precision medicine that we have done in oncotherapy. Can, Tanu madam, can it be applied in our your immunology or your sepsis management? Can we have a very precise individualistic treatment or intervention in accordance to the genotype or phenotype?
Yeah, so the only thing which I can really think of is the expert Carba test, like, in terms of precision medicine. So see, what happens is that when a patient becomes septic in our ICU, we usually start empiric therapy with polymyxin along with tigecycline and one or two beta-lactam, another beta-lactam drug. And we wait for our cultures to, culture bottle to flag. Now, if the bottle flags and they say that there is a gram-negative bug, then we often request a BCID panel if the patient is very sick, or because it can be done directly from the bottle. On the other hand, if it has grown on the plate and we know that this is a lactose fermenter, which is either E. coli or Klebsiella, then we ask for an expert Carba on this. And if we find that it is basically an organism which produces OXA48, and it does not have an NDM, it's not an NDM producer, then we know that we can use ceftazidime avibactam as a drug. On the other hand, if we chose both OXA and NDM, then we basically can use a combination of ceftazidime avibactam and aztreonam, which we are doing a lot these days because we need a companion drug to cholesterol, or we need an alternative to cholesterol. So what I'm trying to say is that the role of these two panels, the BCID panel and the expert Carba, has to be in the appropriate setting where we can use them to modify our treatment. Now, we know that if we are growing a non-lactose fermenter, we can't use the expert Carba because it does not pick up most of the carbapenemases which are produced by Acinetobacter or maybe Pseudomonas. So you can't use it for treatment. But yes, if you are growing E. coli and Klebsiella, then you can use expert Carba for precision therapy. And as far as antibiotic stewardship is concerned, the tests that help us are, for example, the ME panel, the meningoencephalitis panel in a patient coming with meningitis. And if you find a virus, you won't be giving antibiotics. Similarly, a person who comes with a respiratory tract infection, if you do a panel and you find that there's a virus isolated or a virus detected, you won't be using antibiotics. So in that way, I think these molecular panels help in both antibiotic stewardship and in precision medicine.
I completely agree, but I will come to Professor Ashok Ratan sir, that we have had some sort of antibiogram or stewardship program in individual institutions, particularly big institutions, teaching institutions and others. But we have not found this one in smaller institutions and also the diagnostic lab chains. So do you think antimicrobial stewardship program or an antibiogram published by the lab chains, which are actually serving many of the smaller institutions, would be helpful for the smaller institutions to take decision?
Yes, it's also there that microbiology labs just giving the report is only half the results, because by the time the reports come, the patient has already had 3 days of antibiotics. So one of the jobs of every microbiology lab is to collate the information and circulate antibiogram on a 6-monthly or yearly basis to all the clients from where the samples are coming, so that then you can influence empirical testing. So one would be that you do culture, and if you are using Phoenix, then Phoenix now has CPO detect method, where it will classify whether the bacteria is producing ESBL, whether it's producing carbapenemase, and whether it is A, B, or D. So you know that what is the prevalence and what is the incidence of carbapenemases producing bacteria that you're getting. And you should circulate this regularly to the lab. We get a lot of samples from the community from UP and Bihar, and we have collated our 2018, 19, and 20 data, and we'll be circulating it to our group. It should have happened every year, but the software inside the panel is more difficult than WhoNet. WhoNet used to be very user friendly. The software with BD systems is slightly less friendly.
Dr. Ravi, the NHS antibiogram system.
We go on lines of Professor Ratan. We get our antibiograms every year. And to give you an insight, I think one of the biggest problem in part-funded healthcare system, i.e. India or states to that extent, is unless you stop selling over-the-counter antibiotics, all these tests will be pointless. You have to stop over-the-counter antibiotic sale. But that's a different debate altogether, I agree. And to give you an insight, we get our micro. So we have annual appraisals as senior consultants. And my annual appraisal will not be signed off if I get my microbiology accreditation every year. So I have to know what is prevailing in my hospital, what is coming from the community, what should I give, what shouldn't I give. Unless I tick those boxes in the MCQ that I have to do after the appraisal test, I will not get an appraisal. Okay, so we are up to speed on that one, and that's why I said maybe it is the primary care. And to give you last but not the least insight, when we get a community-acquired pneumonia patient in our hospital, what the family physician that you would call, which we call as GPs here, the general practitioner, what they would have prescribed is doxycycline. Now, I'm sure you haven't seen doxycycline for about 10 years, Arindam, have you?
No, we are good with that because of the malaria part, right?
Yeah, so doxycycline is what we would start with. They would come to ED. If they look really horrible and sick, we would escalate it to co-amoxiclav. If they end up in ICU on co-amoxiclav and they are not improving, we'll then go to tazobactam. If they are not improving on tazobactam and we've got some results which are pointing, then we'll go to meropenem. And that is where we'll stop. So it's very different. But as I say, in answer to your question, yes, our education and our training is very up to speed on that one.
Okay, Dr. Mehta has joined, but before I come to him, Dr. Rajadhar wants to comment something.
So quick couple of points. Dr. Ravi Kumar, you would be surprised that the country was actually out of doxycycline during the COVID pandemic. We were actually run out of doxycycline in this country completely. And you know, in patients who come in with, so doxycycline is the favorite antibiotic for a pulmonologist. I'm a pulmonologist because we would give it to someone who has a COPD exacerbation, for instance. You know, you would manage to cover the atypical bugs with it. So I think even the doxycycline have their own position in India. Unfortunately, we have landed up with in a situation where we don't the ceiling is not meropenem, the ceiling is colistin or even above that. The question I was trying to answer, Arindam, a little while ago, you talked about doing these RT-PCR tests and basing your antibiotic stewardship program. So in my practical sense, having done quite a lot of these BioFire RT-PCR tests, the problem is that you have to actually correlate your BioFire test with your culture tests, which come later on. So unless you have more than about 10 to the power of 6 or 7 copies, it's never going to grow on culture. And you end up with about 6 different bugs. So you have an acinator, you have a Klebsiella, you have a staph, you have a couple of viruses which come on that panel. And unless you correlate them with your culture results at a later date, you will never be able to build up a stewardship program based on the molecular diagnostics that you do.
So maybe you would end up rather over-treating. Yeah, and that. So welcome, Dr. Mehta. I will come back to this topic, but once he has joined, sir has some prior appointments, so he had joined late, and he has already informed us that he would be joining late. Anyway, welcome, sir. So I would be bombarding with your 2-3 questions very in quick succession, but the first one would be.
Dr. Kirk,
yes, please.
If you don't mind, I know that Dr. Kumar has to go for bronchoscopy. Can I ask a provocative question to him and probably help Dr.
Yes,
Dr.
please.
Sepsis and Dr. Tanu's help in answering? So I picked up on one point you mentioned about the over-the-counter antibiotic, Dr. Kumar. And in principle, I agree with you completely. And I don't represent the US system at all, but spending 15 years of my life, one thing is, I think when we talk about over-the-counter antibiotics used in India, and as I said, I agree in principle, it may be causing the drug resistance, one of the factors for that matter. However, if we take the resources, the per capita income, and the hospital doctor to patient ratio or the population to serve the doctors kind of thing, I would argue, just for argument's sake or being devil's advocate, I would argue that if you take away, imagine if you take away all the over-the-counter medications, the burden on hospitals for seeing simple stuff will be too much, and that may cause, and that has not been studied. And I am a data scientist. I like when I see the data. I don't think so any study has been done that if you take all it away, the burden it will cause on the system itself, including the sepsis, would be very devastating than what we're seeing right now. Again, I'm not arguing in favor of.
No, absolutely. The point
studies
taken
are not
is
done
it's
yet.
not, yeah, practicality and feasibility in terms of that, it would be very difficult. So that's why it has not been implemented. So we had to pay the price of reaching out to many people, rather, and we ended up with a name. Ravi sir, I would just come back.
But I think when he
Yes,
says over the counter, it only means not getting antibiotics without prescription. So as long as they are prescribed, because a lot of times patients can just go to the counter, get just 3 tablets of amoxicillin and move out.
See, we're discussing 2 extremes. One is over the counter, you go to the chemist and chemist gives you the antibiotic. And second, I thought you go to the hospital on the other spectrum of the whole thing. There is in between. There are GPs in between. You know, so you need a prescription and let a doctor see you and then prescribe, as Tanu said. So I think that is what we are saying. Don't let the chemist dispense the give the medicine, prescribe the medicines. Let the doctor do it. The GPs can handle it.
Yes, Dr. Ravi sir, quickly.
Yeah, absolutely. I agree with sir actually on that one. When I said over the counter, that is exactly what I meant, Tripati. What you said exactly. But if that was just a counter to cause a bit of controversy to Rahul's argument, would be if what he was saying was correct, then half of African continent would come with MDR resistant drugs. What you see in Africa, you don't see that much of resistance in Africa apart from Mycobacterium. You know, you don't see resistance to standard Pseudomonas and Klebsiellas in Africa, right? And one of the reasons is you can't get an antibiotic without a prescription even in Africa today. And that's where lies the difference.
Definitely. We will do someday on a detailed analytics on that, but we should not be deviating from our main agenda today, the current diagnostics of A. So I will come back to the main frame and ask Mehta sir a simple question, because as you are practicing active surveillance of MDROs on most of your patients, sir, can you please elaborate the system that Medanta is doing? I know that is one of the most intricate and very detailed and surveillance that you are doing on your patients. Mehta sir.
Yeah, see, Arindam, what we have been doing is that obviously the carbapenem resistance is going up in the Indian subcontinent, and most of our tertiary care hospitals have a substantial burden of CREs. And once we were realizing that once a CRE patient is there, one nurse does not look after. Very few hospitals have the luxury. We used to have it some one point of time of that one nurse looks after one patient only. So one nurse will look after a few patients in the ICU, and the CRE would spread from one patient to the next and next. So we put a stop to that. What we have now started then doing is that as soon as the patient comes into the emergency room with a suspected sepsis as a provisional diagnosis, and he is coming, he has certain risk factors, which we have a list which is given to the emergency department. That is, recent hospitalizations, recent antibiotics, and so on, he is tested for CRE. So there is a Carba done. Till that time, he's kept on one side of the emergency room or in isolation there. And as soon as it is, say, positive, he has to go to an ICU, or even if it's to go to a ward, he goes to an isolation room. If he is negative, then we can keep it in a double room or whatever, sharing room, or with minimal risk of this thing. So that is what we have been doing, and it worked quite well because the incidence of CRE incidents went down in the intensive care units once we started doing that. There was a around waiting period of a few hours till the Carba report came, and then we found a bed for the patient. But ours is a huge hospital with huge number of ICU beds, so we could do it. I mean, we isolate those patients as soon as we know the results.
Dr.
Panelists, to all the panelists, do you think that can India afford this strategy yet, for the particularly for the smaller institutions who doesn't have enough of isolation beds? Dr. Rajadhar, Dr. Trupti, your take? Or yeah,
I think for us, it will be a challenge, Arindam. I think it's going to be a challenge to try and implement this across the board for all comers. But I think a selection strategy, a high-risk stratification strategy would be something that we could adopt. But I don't see us being able to do this across the board for all patients like Dr. Mehta suggested. I think he himself said that he's lucky to be in an institute where the number of intensive care beds are massive. And I think unless you have a system like that, it'll be difficult to implement in a hospital like ours.
Dr. Trupti.
Yeah, I completely echo what Dr. Dhar said, that in setups that we are in, it's going to be very difficult to actually isolate all patients, and that's also true for most of the healthcare in India. Where public health setup makes majority of the healthcare, and that is going to be very difficult. But I think wherever it's possible, it should definitely be implemented.
So I just want to add that it places a very big burden on the patient also, because once you say that you have to be isolated, means the patient has to go to a single room or this, and you have to put in contact isolation precautions, which are also very resource intensive. In fact, we find it difficult even to put patients with C. difficile infection in single rooms because, they've acquired it in hospital and then you have to ship them there. And also because if you look at the percentage of carbapenem resistance colonization, it is very high. I mean, every second patient you will get is going to be like that. So those are the challenges in, implementing this.
Can we have some sort of concept of cohorting together, even if we cannot afford to have isolation for it?
If there are two CRE patients, we put them together.
Right, sir.
No problem. And one nurse can look after both of them.
And this cohorting system we have done pretty well in the COVID itself. In fact, all of the hospitals are now pretty well equipped with the cohorting system. Maybe in future we can have a cohorting system for the patients who are colonized with CREs or any other MDROs. So, but okay.
And one more thing, there's just one more point I wanted to make, that even if the patient comes and he's Carba negative, Carba resistance negative, in 3 or 4 days of being in the hospital, many of them acquire these pathogens. So that is also something which we should keep in mind. That the rate of acquisition of carbapenem resistance is very high after they come in.
That would be another problem to add up with it. Okay, so I will digress again from a little bit and ask Professor Neelam Verma. And we had a very interesting new, very inexpensive, in fact, an inclusive biomarker, right? The MDW, with Dr. Pose, we presented in front of us. So please give us a little bit of the in-depth analytic or your review of this one, the MDW, how useful it could be, how definitive it could be, and how differentiating it could be. Yes, ma'am.
Thank you, Dr. Arindam, for your question. So as we heard from Dr. Zevu, that there are a number of studies who suggest that cell population data parameters are potentially useful for early detection of sepsis. This parameter, MDW, is a FDA cleared marker for sepsis for adults and used in emergency departments. This parameter is available on Beckman-Coulter instruments. There are two of them, Unicell DXH 900 and Unicell DXH 690T. So you have to have these two instruments to analyze this parameter. Because circulating neutrophils and monocytes are among the first cells to respond to an infection, increase in cell volume is useful for early detection of sepsis and developing sepsis. MDW can be reported on complete blood counts with differential counts from patients presenting to the emergency department. And as we heard from her, high MDW values above cutoff of 20, they are considered as detecting sepsis. So we conducted a study on this subject in our institute, and median MDW values increased from groups like no infection, no systemic inflammatory response syndrome group, to when MDW was combined with white blood cell count, WBC, as told by Dr. Zive, sensitivity and negative predictive value reached 100% for sepsis detection in our cohort if at least one biomarker, MDW or WBC, was abnormal, suggesting sepsis probability is very low if both the biomarkers are normal. For low-risk patients presenting with 1 or 2 SIRS criteria, abnormal MDW results increased sepsis probability 4 to 7 times compared to those with normal results. Abnormal MDW results increased sepsis probability to almost 7 times as compared to normal results. So in our experience, MDW demonstrated high sensitivity and high NPV for sepsis detection in emergency department patients. CBC diff analysis is done as a part of routine workup in all patients. Therefore, MDW can be measured automatically, rapidly, and at a low cost during the routine CBC patients wherever sepsis is suspected. Thank you.
Yeah, Madam, a quick question from the attendees is that what could be the possibilities where the MDW can be falsely high in a non-infective situations, right? Where it could be a less amount of discriminating.
It's correlated with the infection mainly, so it may not be increased in other conditions. It's just that you have to go with the negative predictive value and the sensitivity, which are very high in our experience, and as the published literature also showed.
Okay. Because our experience as an end user, clinician end user, is that most of the biomarkers, sepsis biomarkers which had been marketed, which was always told that they are going to be the wonder drug. Mehta sir will agree with me. But they failed where they were actually supposed to work. So Mehta sir, do you think rather than an individual, a panel of biomarker or the biomarker panel, would that concept help us to have a very clear distinguish between a sepsis infection and non-infection, which can further help in decision making and actually implement our antimicrobial program, stewardship program?
No, that is correct, Arita, because despite so many new definitions of sepsis and so many surviving sepsis guidelines, the new ones are coming in very soon. So much of work is done, we still don't have.
And I must congratulate you for being the Indian representation on the surviving sepsis campaign. Thank you, sir.
We still don't have a specific one biomarker which will tell us the patient is septic or not. You know, unlike, say, if your anti-proBNP raised beyond a level, you know that it is heart failure. If the TROPA is raised, you know it is ACS. But for this, we do not have. So we have to, first of all, when you do a biomarker, you have to have a clinical suspicion. That means a clinical suspicion should be there. I mean, you have to see the patient and then figure it out whether the patient is likely to have sepsis or not. And then you concentrate on whichever biomarker you need to do. And at the moment, we do not have it because procalcitonin, which is extensively used, particularly now with the COVID pandemic, it was used very, very extensively. The procalcitonin, primarily the evidence is for de-escalation and prognostication, not for diagnosis of sepsis. So it has, all these things need to be put together. So whichever 2-3 easiest, cheapest modalities which we have, which put together will confirm the diagnosis with the high specificity and maybe sensitivity, like this one has a 100% sensitivity, which is impressive, would be a useful tool, particularly in the emergency department, because none, let me be very honest, we are from different parts of India, no hospital, the surviving sepsis 1 hour bundle is found. None of the places. And the biggest, this thing is the young doctor in the casualty emergency room at night time. You know, you is overly swamped with work and will be difficult, is not adequately supervised. So if we have 2-3 simple things for him to do, if we are suspicious, which put together confirm the diagnosis, it would make things easier.
I think Dr. Ravi Kumar wants to contribute, sir, on procalcitonin. He's jumping in his seat, and maybe he has to leave in a 5 minutes time. Yes,
No,
sir. I know you have a lot to tell about PCT.
No,
Yes,
I'm more jumping in the seat because I've got to go.
The wrong part, yeah.
Obviously, I think Dr. Mehta nailed it on the head. You absolutely nailed it on the head, sir. The way PCT is used. So I brought procalcitonin. I was one of the first users within the UK going back to 2007. And following that, we were heavily involved in the biggest procalcitonin trial to date, which was called the ProHosp trial in 2009. And I know procalcitonin has absolutely exploded over the last 20 months or so, ever since the pandemic hit. And you're absolutely right. How do we use procalcitonin? So for diagnostic purposes, to start an antibiotic, we only and only use it for pancreatitis and no other pathology. We will only use it for pancreatitis when all other numbers, all the SIRS responses, all the SIRS markers are out of the window. You don't know what is happening. Is this stress or is this infection? We'll do a procalcitonin, and that too will do serial ones rather than one absolute figure, and to decide whether we should give antibiotic or not, because about 60% of our severe acute pancreatitis. So severe acute pancreatitis by definitions are the ones who are admitted to intensive care. So 60% of them will not be on antibiotics and will not get antibiotics at all. So we are guided by procalcitonin on that one. But what we do use procalcitonin for, and what we have used over the years and years and years, is to stop antibiotics. We are more confident in stopping an antibiotic based on procalcitonin figures rather than starting an antibiotic on an absolute procalcitonin figure. We would never be. Coming about procalcitonin and prognostication. And when you say prognostication, it is not the risk of morbidity we are talking a risk of mortality. So if I ask you a question directly, that can a procalcitonin level predict death? The answer is actually yes. You have to use it often to realize the trends, how it is working and how your labs work and all that. But if an arbitrary figure of a procalcitonin level, which is about 50 to 60 times your normal reference value from the lab, is a very, very strong predictor of mortality. And we are only talking intensive care here. I'm not talking ward-based settings. That is all I had to say.
And then I think it was quite good information from all of us. And very quickly on the last question on the biomarkers to Tanu Madam, Trupti ji, Dr. Rajadhar also. Can we extrapolate our experience that the guidance that interleukins gave us during the COVID, right, particularly to detect the severity or the cytokine storm? Can it be extrapolated to non-COVID situations, particularly sepsis? I will start with Tanu Madam.
Well, actually, even when in the COVID pandemic, when we started, we thought that IL-6 was a useful marker. But gradually, as time went by, we realized that IL-6 really does not help in any decision making, really, even as far as starting tocilizumab is concerned. So we have learned that probably CRP is the best marker as far as COVID-associated, cytokine storm is concerned. And in terms of IL-6, I think is a marker. I mean, it rises in very many conditions because it is actually the precursor to CRP. You know, your IL-6 rises first, which then stimulates the cells to produce CRP. So it may rise faster, but it is highly non-specific, and we see very high levels in sepsis as well. And the other problem with IL-6 is that it has to be done in a proper way, you know, because you have to send it immediately to the lab, and sometimes you may have false results. So I don't really feel very enthusiastic about IL-6 as a sepsis marker. It didn't really help in the COVID setting also, now as we look at it in retrospect.
Dr. Dhar, your take on this.
So I agree with Tanu. I think IL-6 I would never use either for monitoring of an infection or for prognostication. I still would not give a drug like tocilizumab to someone who's got a very low IL-6. So I would use it for its negative predictive value. I wouldn't think that tocilizumab would work in someone who's got an IL-6 for 5, for instance. So that would be the only use of IL-6. I think when we talk about Procal, I completely agree with everything that was said. But in addition, I think a singleton value of something like an IL-6 of Procal of more than 2 has been found to be a predictor of mortality. So I think if you're doing an IL-6 at the end of therapy, and if you find it's very high, I think it becomes the responsibility to try and find out why the Procal is high in that individual.
Dr.
Chemical infection control as the Procal is.
Okay, and Trupti madam, your take, and then I will take 1 or 2 last questions.
Yeah, I completely agree with both of them. Even with COVID, we only probably started using IL-6 at the start, and even that was never based on a single value. It was always based on if you were seeing a rising trend. But we've never used IL-6 for sepsis, and we don't use it. All that we use is CRP, along with the hematocrit and the PCT, just to decide the duration of the antibiotics.
Okay, so last 2 questions, which actually has got some relevance to our practice, right? And then I will come to all of you.
Dr. Kerr, Dr. Jay Wei's hand is raised for a while.
Oh, sorry. Yeah.
No problem. Thank you. I just wanted to have.
Sorry on that.
Yeah, no problem. I just wanted to maybe address a comment earlier that MBW may be elevated in other conditions.
Yes.
It is true that, you know, when the white cells are responding, MBW will be elevated. But I think some of the feedback we've gotten from physicians who use MBW, they say that it's a good rule-out marker for them, especially for, I think, the younger physicians in the middle of the night in the emergency room. So if a patient comes in with certain clinical signs and symptoms, but MBW is normal, white cell is normal, then, you know, they could possibly send that patient home with a better peace of mind. And this is also part of the negative predictive value that we have seen with MBW.
I'm extremely sorry to not to see that you have raised your hand. I would have come back to that part. Yeah. Okay. So we are almost there. I would take only 2 questions, and I will go to all the faculty before closing and handing over to Deb Kishore to thank every one of you. We have seen a lot of empiric prescriptions, which has got a combination of carbapenem and an MRSA coverage, most notably the teicoplanin, right? So, and in Indian context, I know this is pretty important in US, UK, the incidences of MRSA is much higher. But in an Indian context, do you think this combination is pretty rational for an empirical coverage? I will start with Mehta sir and then go to all of you.
See, first of all, Arindam, I think over the years, the perception is changing that we don't have MRSA. We are racially different and we don't have MRSA. That's not correct. MRSA is increasing. Now MRSA is in the community, as you are aware of the Hinduja papers.
Right, sir.
So MRSA is increasing in all the tertiary care hospitals. And gram-positive sepsis is also increasing, not as bad as the Western data. I agree, we still have a gram-negative sepsis board, but MRSA is not an insignificant problem, particularly in the tertiary care hospitals. So yes, if your patient is on vasopressors, hemodynamically unstable, he is in septic shock, it does make sense to give a broad spectrum antibiotic coverage, wide antibiotic coverage, like a MRSA cover along with the gram-negative cover. So carbapenem along with MRSA cover initially does make sense. in tertiary care hospitals. Yes, depending on where the patient is coming from, if the patient is coming from multiple other hospitalizations or has received antibiotics or these drugs, similar drugs in the previous hospitalization, then you may think about poly B or colistin, depending on your own antibiogram in the high degree of suspicion.
Ashok Shah, your experience on the samples that are coming from community, incidence of MRSA.
Yeah, MRSA seems to be going up and down. So it's not constant that it is, but about 30 to 40% of all staff audios that we isolate, they are MRSAs. So
and overall incidence, if we take the overall incidence of the positivity, both gram negative and positive, what would it be around? Because our Indian studies have shown, yeah. Yes, sir.
Gram negatives are more of a problem now. There was a time when MRSAs and VISA were being thought about, but then a lot of new drugs which had activity against gram positives became available, most notably linezolid, daptomycin, and quinapristine. And as a consequence, it is the gram negatives which are more and more problem. And initially, they used to be meropenem used to be nearly 100% sensitive. Now it's about 50% wherever. I was just reviewing my ceftazidime avibactam data, and in 2019 it was 100% sensitivity. Now it is 60% sensitivity in Klebsiella pneumoniae. So it's gram negatives are the ones
more of a problem. Tanu madam, any particular subset of patients where you should really
community acquired infections, if a patient is coming with a community acquired sepsis where the source appears to be skin, soft tissue, bone or joint, and the patient is sick, I think we should give an anti-MRSA cover. Or if he comes with a community acquired pneumonia, necrotizing pneumonia, rapidly progressive, maybe there is a role of adding an anti-MRSA cover in the beginning. But if the source is a urosepsis or something else, then there's no need. As far as hospital acquired, and one more important thing is that MRSA is fairly easy to grow on the blood culture. So even if you've started an MRSA antibiotic, after 48 to 72 hours, if your blood cultures are negative, you can think about stopping it. Now, in terms of hospital acquired infections, actually it depends on the local antibiogram. So, I mean, for our hospital, we've not had a single case of, MRSA in the past 2 to 3 years. So therefore, if a patient gets hospital-acquired infections, we don't add an anti-MRSA cover. In fact, our antibiotic is polymyxin with carbapenem or other drugs because we see more of resistant gram negatives. However, the gram-positive drug agent which is causing a problem with us is enterococcus. So our enterococcus rates are higher as compared to our MRSA rates. And in that situation, if we are suspecting enterococcal sepsis, we might add a drug like teicoplanin also, but then we add it for enterococcus and not for MRSA.
Dr. Dhar, very quickly, MRSA pneumonia, how frequently you are seeing, because you are one of the topmost pulmonologists in India itself.
So I think I would go in lines with what Dr. Yatin Mehta said. I would, if a patient comes in and it's a pneumonia, patient is in sepsis, got septic shock, hemodynamic compromise, I would cover these patients for MRSA. I would give them a teicoplanin to start with. And then in lines with what Tanu said, I would actually de-escalate the gram-positive, the MRSA cover early if the cultures came back as all being negative. So that's what I would do.
Trupti ji, anything to add on or differ with?
No, it's the same pattern. We aren't seeing that much MRSA even in the hospital-acquired infections that we are seeing. So we only add an MRSA cover when it's skin soft tissue from another hospital or has had a recent hospital stay or on hemodialysis. With intra-abdominal, pelvic, urosepsis, we just don't have a MRSA cover at all. And we actually don't see that much MRSA anyways. Except in
okay, definitely. Okay, the last question, that now that the COVID seems to be on a lesser incidence going down, but other respiratory viruses, infections are particularly due to the monsoon. do you think the early detection and differentiation of influenza, SARS-CoV-2 and RSV would be very helpful, and if it can be done in one singular platform? Yeah, Mehta sir.
No, see, because so much of awareness about COVID, every one person sneezes at home, you test him for COVID. Now patient comes in with some sort of pneumonia or LRTI, and we just test for COVID and forget about the other viruses. So that's discrimination. I think it'll be nice if we have one method where we can know that if the patient has some other significant respiratory viral infections. So that will be certainly useful, because we tend to ignore, particularly now, all of us now, patients are undergoing more solid organ transplants, more bone marrow transplants. There is more leukemias and oncology patients, immunocompromised patients. So you have to, it will be nice if we know if the patient has some other viral sepsis also, so that we can give him the medication. And swine flu also patients. Yeah. So if you, in one go, if you can know what the patient has, it will make the treatment easier.
Dr. Dhar, what about this one? Patient comes with ILI and you have all in one platform. At least you can initiate actually a directed treatment, and maybe you can spare some antibiotics on that part.
So true, and so to both sides, I think if a patient comes to me to a tertiary care hospital spending all the money that we charge, the patient is generally actually quite unwell. It's probably more than an ILI in that case. And if you manage isolate influenza, Dr. Mehta spoke about swine flu. There are particular drugs, directed drugs that you can prescribe, antiviral agents that you can give to these patients, and the patients get better. Second, if the patients are really unwell, and if you find a background viral infection, you would actually look for a secondary bacterial infection in these individuals to find out why they are so unwell. And I would have a low threshold in this population to try and do a balance, isolate a secondary bacterial infection on top of the viral infection in these patients. So I think it's important from those perspectives. The epidemiological data is also important for our country. It's all become COVID and non-COVID. Those are the two classes of infections we have in our country today, and that needs to change.
Okay, thank you. So we had a long discussion, almost more than an hour, and I will ask Dev Kishore to ask for all our panelists for concluding remarks and also close the session. Yeah, Dr. Dev Kishore.
Yeah, thank you so much for this active interaction and these wonderful comments coming from the esteemed panelists. So definitely I'd request one concluding or closing remark from each of the esteemed panelists. So I'll begin with Professor Dr. Ashok Ratan sir.
I think the time is right now for a syndromic approach to most of the diagnosis, so that one go, the right diagnosis is made quickly, so that then directed treatment can take place rather than a step-by-step treatment, the diagnosis and treatment.
Dr. Trupti.
I think while we make all these efforts on diagnosing bugs and treating drug-resistant bugs, I think the most important thing that we often forget is actually making a consolidated effort to prevent and tackle this entire issue of drug resistance, because it's only when it comes to us that we try to treat it, but it all starts much earlier in the community, where drugs are being prescribed right, left, and center. And I think as a community, we really need to do something to prevent that drug resistance before we won't have any more options left.
Thank you. Dr. Rajadhar.
No, I think in line with what's said, I think we need to go a step back. Isolation of the patients in proper areas, making sure that preventive policies like hand washings, etc., are in place and implemented properly. Looking at antibiotic stewardship programs, including the molecular diagnostic methodologies that we spoke about. All of that needs to be focused on going forward. And I enjoyed the discussion today. Thank you.
Thank you. So Dr. Yatin Mehta sir, any take-home message from your side?
First of all, Dev Kishore, thank you for getting me here, although I joined late, but it's nice to see some old friends on the panel. Dr. Ratan, I'm seeing after many years, and Dr. Dhar is a dear friend of mine. Anyway, so now, see, we spent thousands and thousands of rupees on empirically giving antibiotics to the patients. And not only will we increase the cost to the patient, but also the burden of MDR we are increasing by inappropriate use of antibiotics. So if we have an early diagnosis of sepsis, along with a causative agent, which can be done in a short turnaround time, then I think it will save a lot of grief to all of us and have a more directed therapy and stay in the hospital rather than just treating everything blindly. So yeah, it will be useful to have.
Dr. Rahul Kashyap, please.
I thank you so much for the invite. It was a humbling experience being in the company of the giants and so many, talented people here on the call. I was doing shameless plug on some of the papers we have published. I would like to invite all of you as a panelist, as well as our listeners today and participant to join me, Dr. Kerr and Dr. Gupta. If you have ideas, survey, retrospective, prospective study, that's what I do for a living. COVID, non-COVID, especially in sepsis, and as Dr. Tipti has mentioned, antibiotic stewardship areas as well. I'm sending my email IDs and everything to all of you. Please join us. Please reach out. I know you all are busy clinically. Just open your mouth, see what ideas you want to study. And we have an army of people who can do that. Many of the students are looking for projects. We'll be happy to work with you on your ideas and have you publish as a first author. So with those words, it was extremely amazing experience, and I'm really humbled. I hope I'm not turning too cynical as my gray hairs are coming up.
Thank you. Dr. Tanu Singhal, ma'am.
No, I think I agree with whatever has been said. And then sometimes it is better to invest in investigations rather than in medications, and it is cheaper in the long run. So if you, because, sometimes we have this block that, it's so expensive, but maybe it turns out cheaper in the long run for the patient and also in terms of antibiotic use. And second, people should also look at cutting down duration of antibiotic therapy, which is an important part of stewardship, because we are always used to giving 10, 14 or 21 days of antibiotics. And now, even if using procalcitonin, you can actually cut down duration of antibiotic therapy. That will also help prevent resistance.
Thank you so much. Professor Nilam Varma, ma'am. Can we have your comments?
Yeah. So I would agree with Dr. Mehta and Tanu that we should try to reduce the cost of investigation. And I would recommend the MDW to be done as a part of initial workup. Doesn't cost anything extra, doesn't require any extra sample, very rapid turnaround time. So I think we should give it a chance. We should try it out and see how it pans out. Thank you very much.
Thank you so much. And at the same time, I would like to thank Dr. Arindam Kar for the wonderful questions and for conducting this great moderation. And I thank everyone for their presence and for their precious time, all the valuable inputs. I'm sure this will help us in a long way. Thank you so much. And Dr. Kaur, if you want to add anything.
Yeah, nothing, Krishna. Thank you. And thanks to all of us to give us almost 1.5 hour time and be with us. Thank you. So we'll come back pretty soon with some more interesting topics and invite you for some engaging discussion. Thank you, sir and madam.
Thank you, everyone.
Thank you.
Great evening.
Have a good night.
Everyone.
Thank you.